Hi there, everyone. Welcome. It's Saturday, June 27th. It's 11 a.m. On the East Coast of the United States. Thanks for joining us this week. Thank you for being a part of our community and setting aside some time on your busy weekend from friends and family and maybe even a little bit of work to advance your knowledge and learning in this topic. Today, we have a really great presentation. We're going to talk for probably about 30 minutes. In a moment, I'll introduce to you Dr. Jeremy Fletcher, who is a primary care physical therapist in the VA. And he's going to share some of his experience and knowledge and really wisdom of many decades in how to support men with their own mental health and mental well-being. The webinar will probably run for about 30 minutes or so, give or take. And at the end, we'll have some time for some questions. And if you're not with us live and you're watching this via replay, I know a lot of people watch these webinars via replay. Just know that we thank you for setting aside your time and even watching this in the replay and for being a part of our community. Okay, without further ado, I'd like to introduce Dr. Jeremy Fletcher. As you know, he is a primary care physical therapist at the VA. He's also on faculty here at the Integrative Pain Science Institute, where he teaches two courses, one on trauma-informed pain care and the other on the mental health physical therapist certification program. Okay, without further ado, Jeremy, it's all yours.
Great. Well, thank you, Joe. And it's great to be with everybody this morning. I'm going to go ahead and get us started with our presentation, and I'll share the screen. I'll tell you what, before that, I do want to just briefly mention that this month is Men's Mental Health Month, which is why we felt like it was really important to bring this topic today. And it's also PTSD Awareness Month. And that's another reason why we wanted to bring this to you today. So I'll expand on that in just a moment. In the meantime, I'm going to share my screen so we can get the presentation started. All right. Again, grateful to be here engaging men in mental health, practical strategies for the physical therapist. As Joe said, I work as a primary care physical therapist in the Veterans Healthcare Administration in the United States. In that role, I'm a primary care physical therapist. And so I bring a lot of clinical knowledge and wisdom, as Joe said earlier, to this particular topic, and grateful to be here. I also want to disclose a couple things about myself. One, I have a lived experience with PTSD, anxiety, and depression. And honestly, as a mental health physical therapist, I've found a great deal of meaning and purpose in my own life by helping men navigate those situations, especially veterans. So shout out to my veterans that have paid a high cost of service for our nation's freedom. A couple other disclosures as well. The views expressed in this presentation do not represent those of the Veterans Healthcare Administration. They're my own opinions and ideas. This webinar is intended for licensed healthcare providers only and does not establish a patient-provider relationship. The content includes discussion of psychological distress, trauma, and may reference suicidal ideation. And most importantly, this material supports psychologically informed physical therapy practice, but it does not constitute training or competency in this particular area. So with those things being said, let's talk about today's objectives and what my hopes are for this particular webinar. My hope is that we can all describe how men may communicate psychological distress differently than women and how they present to us in the clinic. I also would like for folks to be able to walk away with a very simple 3R framework that can be used to support men's mental health in clinical practice. I would also like for us to be able to use one practical communication strategy to foster participation-centered conversations. And I'll talk about that in a few moments about what that means. But hopefully those are the things that you'll be able to take away from this webinar today. We actually know a great deal about the differences between men and women and how they engage in mental health care. I've done a lot of work in the veterans population, and I can tell you from work that I've done in the past that about 50% of veterans will have some sort of mental illness at any given point in time. Of those 50% of folks, another 50% of those will likely seek care. And of those that do seek care, less than 25% of them actually receive evidence-based mental health care. And the same, for the most part, goes for men at large. So we know from plenty of research that men are less likely to seek mental health care support, and that often men present to us with somatic symptoms. And they may express things like depression through irritability and risk-taking, substance use, avoidance, or, as I said, these kind of somatic representation of a deeper pain experience. Men often define health in their minds and in their own constructs and core beliefs through the way they function, their independence, their work, and their social roles. And one of the ways in which we can better serve men is to make very action-oriented, goal-directed conversations that improve engagement in participation in care processes. So this is really what we know about the evidence base in terms of why men may present differently to us than women do. Throughout my practice, I have learned to shift my thinking. And that thinking shifted when I sat in a room with a young intern who was a female, and I was a male, sitting in that room observing men, and she was going through a typical standard examination and subjective evaluation process. And what I saw was men kept looking to me while I was in the room with her. And what I began to notice was they did not want to be vulnerable with this young female. They did not want to explain their emotional experiences. They did not want to describe what their pain was telling them or how they wanted to communicate their pain. And that was pretty profound. It was a pretty profound moment in my life when I realized, like, wow, men describe suffering through changes in their roles and participation rather than emotional language. And that was a profound shift for me. And I began to think in different terms. And I also opened up the questions in my subjective examination much differently. Knowing that I'm not going to hear emotional language, I'm more than likely going to hear things that are role dependent. So I began to ask different questions. And one of my favorite questions to ask is, I ask this of all my patients, but I ask them, what is the thing that what is the thing that pain has taken away from your life? And if they not are able to really communicate that very well, the next step, which always gets a really great conversation going, is tell me what life looks like for you right now. Through that conversation, I begin to hear about those roles. I begin to hear about the meaning that they're either gaining from life or losing for life. I hear more about how life might be constricting, or what are the opportunities that I might be able to help facilitate to restore expansion of their life. So these are two really profound, fundamental ideological changes and shifts that have occurred in my practice that I really felt was really important for me to share with you today. And it also leads us into a new way that I begin to think about this for men. And it's a very simple framework. And within that framework, I call it the 3R framework. And it's really just a practical approach for engaging men in rehabilitation. And the first part of that is to recognize. We want to recognize what has changed and what has shifted in their life. We also want to respond. And we want to respond to what matters most to their lives. We also want, most importantly, to help the individual reconnect with what matters most in their life so they can return to some sort of meaningful participation in life. Ultimately, we have one goal with working with men. It's to restore meaningful participation. So what I want to do is describe each one of those in a little bit more depth, something that you might be able to start thinking about and talking about in your clinic tomorrow. So we want to recognize essentially what has changed. When I consider the things that I listen to and for, I started listening to what has shifted in their lives in terms of the meaningful activities they're no longer engaging in. What have they stopped doing? What are the daily roles that they're assuming that they're not engaging in as much as they'd like to anymore? What are the relationships in their lives that matter, and what has changed as a result of their pain experience? And then what challenges to their identity have occurred? Most men have two thoughts. What am I doing, and who am I being? Who do I want to become? And those are the major challenges and shifts that happen when someone has a pain experience. And finally, what has changed in terms of their ability to participate in daily life? I think whenever I'm putting in those sets of ears, I start to hear things much differently, and that allows me to move to the next part of the framework, which is to respond. And the response that we want to have as a clinician is one that's the most powerful response we can ever have with any individual that's suffering, but especially men. It's just to be curious. It's to have a sense of curiosity and seek to understand what is it that this person has lost that's meaningful to them? What is it that's giving their life meaning? What roles matter most? Is it a father? Is it a coach? Is it a husband? Is it a provider? Is it a what role are they participating in right now that matters the most to them? And then what would they love to get back to doing? That's probably my favorite question to ask. Is what would you love to get back to doing? It indicates passion, and it indicates drive, and it indicates these powerful emotional experiences that we all have and can cultivate even stronger. And then where are they struggling? Where are they having a difficult time right now? So that's the second part, is to respond. How do we respond? We respond with curiosity, and we ask more meaningful questions. We also want to focus our intervention strategies, if you will, on reconnection. So we've moved from how we want to ask questions to how we want to respond to now what do we move and shift our focus toward. And so most importantly, we want men to help return them back to meaningful participation, help men reconnect with their families, help men reconnect with their friends, help men reconnect and participate more fully in their work, help men take on hobbies and recreation that actually help restore their nervous system to a balance. Many of my people that I serve use their faith as a way to cultivate intrinsic resilience for themselves. And so sometimes that's lost. So we can help restore them back to that. A lot of men also, when they're depressed and anxious and have those types of feelings, they tend to isolate. So how can we reconnect them back to a community that gives them a sense of belonging? And then finally, and this may be because of the men that I particularly work with, but veterans have a value system that's steeped in serving others. And so it's really important for them to return back to some sense of service to their community or to their family. So we want to reconnect. So I want to give you a little bit of a case illustration about what this looks like in clinical practice. So I generally use a couple of tools to help facilitate that conversation and make it a little bit easier. The two tools that I generally use on every single person is the PEG scale. The PEG allows me to understand what is it that they enjoy in life and what is it that pain's taken away from their life. And I love to ask the question because of the dialogue that it facilitates. It also gives me an objective measure. And so for this particular young Marine, Marine veteran who was 27 years old, that had presented to me with chronic low back pain, he told me that pain was moderately interfering with his life. And I asked him, what are the things that you would love to get back to doing? and had him rate those using the patient-specific functioning scale. And he indicated that it was running was a thing he couldn't do anymore, and that he would most like to be able to get back to doing. And because we had already talked about in the initial evaluation about the important role that emotions may play, we had also used a screening tool to help us understand his mood. And he scored a 13, indicating that he had a moderate level of depression. So all of this being said, we have this picture of this young Marine veteran who has now shifted his life roles from one of service to reintegrating back into a community. And there's a transition that he's a part of. And he's got a family, and he's got 3 children, and he's got a new job. So there's a fair amount of transitional distress that's happening in his life as well. And so we can take this from this lens of, okay, here's what we know. But if we kind of step through our process here, we recognize the shifts that are occurring in his life. And now we can begin to respond. And so one of the more important ways that I heard in his response was, we started taking walks because that's the only time my wife and I got to spend time together. And to me, the profound, deep meaning there is he is wanting to re-engage in a meaningful relationship with his wife. And that is probably in part why his mood is fluctuating, why he's having this transitional distress. And so then it begins to, then I begin to get curious. How can we return you back to spending time with your wife so that you can participate in your role as a husband better? And that shifted our whole dynamic. And he began to think of ways in which he could cultivate more time with his wife, more meaning and more participation. And so we did eventually, set up a treatment program. But the most important part of that program that he felt like was impactful for him wasn't the stretches, or wasn't the pain education, or wasn't any of those things. It was literally, my wife and I are going to take 15-minute walks every afternoon, and we're going to talk about our day. And those are the things that started to shift his depression. Those are the things that started to shift his sense of purpose, his sense of meaning, and his sense of belonging. So it was just a profound shift. And I think it really is a great illustration of the 3R framework. So again, let's kind of look back at how that worked out for us. So we recognize what has changed. So in our young Marine veteran here, what has changed? What he was not getting the connection that he wanted and desired with his wife. He was working hard, working long hours. He wanted to be a great father. He wanted to be a great husband. These are things that he wanted to do and who he wanted to be. And I think those are the 2 most important things to recognize there. And we responded by genuine curiosity, right? Like I said, hey, what would be the one thing that you would love to get back to doing? And he said, well, the thing that my wife and I have been talking about is this. And that's what mattered most to him, was his role as a father and a husband. And then we talked about, how can we make this connection happen again? How can we restore meaningful participation? And so that was the thing that really fundamentally shifted his depression. But guess what? It also shifted his pain. And so he began to feel better, he began to move better, and he began to do the things he wanted to be. So I want to say a couple things here. One is that when we integrate mental health into our clinical practice framework, we don't have to become a mental health provider. What we really strive for, and the unique skill set that a physical therapist has, is to see the whole person, the way in which they're engaging in life, the way that they serving roles in their family, in their communities, and what is it that is becoming a barrier to moving forward in life. Those are the key skills and abilities we need as mental health physical therapists that allow us to be more expansive and to care for the whole person. And so as we begin to consider how it is that we care for the whole person, I want to introduce to you the Mental Health Physical Therapist Certification Program. The Mental Health Physical Therapist Certification Program was developed with that particular idea in mind. Joe and I had years of experience in working with caring for the whole person, and we wanted other people to have those skills as well. So the benefits of the Mental Health Physical Therapist Certification are expanding your skill set, addressing a real and growing patient need in today's society, improving both mental and physical health outcomes. These are the most profound benefits of the certification. And the certification has 3 components. There is the Mental Health Foundations component, the Mental Health Essential Skills component, and the Mental Health Mastery component. And we've done a really great job of introducing this to approximately 50 to 60 physical therapists. We've tested this framework, and we know that it works. And so now we're offering this continued certification to help other people get the skills that they need. And it is for 30 CEUs for PTs and PTAs. Throughout the course, we use evidence-based teaching approaches like case-based learning, discussion forums, patient simulations, community forum, and then support and mentorship throughout the certification. We also use microlearning, which is a teaching method that uses short, focused pieces of content to help learners learn new information. So what I want to do now is introduce you to some folks that have gone through our certification and allow them to speak to what the certification has done for them.
Really step into that role as someone who does integrate mental health and physical health.
This process for me has been reaffirming. We can do this. So we need to do this for our patients because we need to treat them as a whole.
Participating in this, I feel more empowered and relaxed to be able to practice the way that I always intuitively practice.
It's been really very eye-opening. So thank you guys.
This course has been so helpful to me. Before I was just documenting the actual PT stuff. Now I'm documenting the mental health aspect, and I just feel like it's been, as Jeremy said, transformative for me, for my patients.
There were these moments when I didn't know how to intervene, and now instead of being just a listening ear and empathetic, I feel like I have more of an opportunity here.
My patients love that I am addressing the physical alongside their emotional and psychological health. I'm using these skills in the clinic as well as in telehealth appointments. It feels a lot more rewarding to address not only the biomechanical, but also the psychosocial aspects of care.
Actually having tools that are within our scope and our role to utilize is just so needed and empowering, I think, as a PT.
PTs don't know how to screen, and then they don't know how to intervene, which I think is exactly what you guys have brought to us here, and it's been great.
What I appreciate and am excited about is that ability through the work that we're doing in the modules is to be a bit more introspective in how we're coming to the table to meet someone where they are.
This course has been truly transformative for me and for my patients and the community that I work in. Very excited for to bring this into my practice within this framework and take it forward from there.
I realized that there were component parts where I was ineffective, and I appreciate that this is filling that gap.
I could not be more grateful that you wrestle with the standard of hard lines. This is a physical therapy. I love the wrestling. I love the pioneer spirit that you guys have, and being a part of that has been really, it's really been transformational.
As a therapist, I haven't seen any courses like this, so it's really innovative and transformative in the way we view ourselves as physios, and I think it's a huge step forward for the profession.
I think physical therapists really are the best profession to treat the whole person.
It's great to see those videos and to reflect back on the times that we had with those folks throughout the certification. These are skills that you can use in a variety of different settings. There is a high demand for mental health physical therapists. Regular traditional PT clinics, DPT program are integrating this work into teaching students how to lead our profession in the future. We know of several colleagues who are in addiction care that have integrated this into their practices as well, mental health clinics and primary care behavioral health clinics, much in like where I live and operate now. And we also know of several folks that have used this certification through consulting with technology and other stakeholders. So I think the market is set for people to begin to engage in this work in a deeper and more meaningful way. And the mental health physical therapist certification is a recognized certification. You receive, as I said earlier, 30 CEUs for physical therapists and physical therapist assistants, gain practical skills and knowledge, receive live support and mentorship, and of course you get lifetime access to materials and resources. And because we've used an evidence-based strategy of micro-learning, we hope this saves you time, money, stress, and heartache, and really is at a fraction of the cost of a master's of counseling degree or a PhD to become a psychologist. Joe and I have really taken a lot of our time, wisdom, energy, and effort and practice and skills and integrated this and distilled this down into really the skills that we believe you need at a fraction of the cost compared to other educational offerings. So, and then of course, we're always working to build a more comprehensive network of professionals to continue to expand this work as well. So I just want to bring, we're really excited about this work and glad to offer this to you as well. With that being said, I will open it up to questions and I'll stop sharing my screen, Joe.
Great. Thank you very much, Jeremy. So there's, as people are kind of just reflecting, maybe they can take some time to place some their comments in the chat thread. There are a couple of things that came up during the webinar. I wanted to just pose a couple of questions to you. The first was, in that case that you mentioned, there were some screening tools that were there. One was the PEG, the PEG, one was the PSFS, and the other was the PHQ-9. If you can just maybe just briefly mention what those acronyms are and what each screening tool is actually screening for.
Yeah, sure. So the PEG screening tool is actually a pain screening tool. It looks at 3 specific things. One is pain intensity. That's our traditional numeric pain rating scale, where we place someone's pain intensity experience on a scale of 0 to 10. 0 is no pain, 10 worst pain imaginable, and they rate that. The next question is one where we're asking them, within the past week, how has pain interfered with your enjoyment of life? So pain enjoyment of life is really an excellent opportunity for someone to share with you how pain is impacting the things they enjoy doing in life. And then the next question is really how pain is interfering with general activity, which is the G component of PEG. Another place, especially again for men, keeping it within the context of this webinar, is really a great place to listen. Listen to what it is that a man is communicating that's taking away from his life right now. The other one that I used was something called the Patient-Specific Functioning Scale. And it's really a scale that allows someone to identify the activities that are most meaningful to them and place those on a scale where 0 would be they're unable to participate or do those things. In 10, they're able to do those things as much as they'd like, essentially. So that allows us to set a nice framework for where they want to go in life. And the PHQ-9 is a validated screening tool for depression. It allows you to at least categorize to some extent the extent that depression is playing a role in someone's pain experience, or so in this particular case, he was exhibiting moderate levels of depression. So that enables us to be able to develop intervention strategies specifically for his depressive symptoms. In this particular case, it was merely helping him return back to walking with his wife, to be able to communicate better, to be able to have a shared experience in life and be able to restore connection to his wife. Yeah, does that help out, Joe?
Excellent. That's a great overview. And I also put the abbreviations of the three tools into the chat thread. They are brief tools. They're easy to use or easy to administer with your patients. Every time you use a tool, of course, take the name of the tool off the top, because it just helps the patient not feel like they're being screened directly for something. They just
Mhm.
ask, obviously, general questions about their health. There's something else that came up in the webinar. I was really happy to see the word identity in that first slide of the framework under, I think it was recognized, if I remember correctly. Um, Identity is a really interesting word that doesn't receive a lot of attention or airplay in the physical therapy world. So I was happy to see it there. When you're working with someone, when you're screening, when you're taking your history, when you're listening to their story and what they've been through and how they're suffering, what types of things are you listening for? What types of things have you heard that make you think, oh, there's been a change or a shift in someone's identity, and this may be something that we work with in physical therapy.
Yeah, I think it's more, it happens more frequently than we certainly think about. And I'll give you my experience working with veterans predominantly because there's a great amount of literature that talks about the military as a culture and then that reintegration process from a military culture back into a civil society and how difficult that transition is. And it's predominantly because you're shifting your identity from one of a warrior, one who has a certain warrior ethos, a certain value system, a certain belief system, a certain sort of code and ethics, to now a civil society that operates differently than the culture that you had previously. One of the best illustrations that I've seen that really describes this has been that of somebody called it the monkey bar transition. So it's a point where you're holding on in one hand to your identity as a warrior and you're transitioning to a civil society. And at some point, you have to let go of one in order to grasp the other. And so that's an identity shift. And that happens in that doesn't just happen from one warrior culture to another. That happens as we age, like as we grow. Those types of identity things happen all the time. If you just looked at aging alone and looked at that process, there is a constant shift and change in that person's identity because of the loss of function, the loss of participation, the loss of those things. So people grapple with that all the time. And so I think their identity is often formed because in changes and shifts based on how people are seeing you. That's how our identity is expressed and developed, how people see us and how we see relating to other people. So I hope that answers that question, Joe.
Yeah, and then just a follow-up to that. So with regard to physical therapists, having the ability to shape someone's
Yeah.
identity, it sounds like the primary way that we can kind of conceptualize that is through participation and in the
Mhm.
various ways that people are participating in their life with their family, their friends, their community, their faith, et cetera, et cetera.
Absolutely. Yeah.
Excellent. If you have any questions, you can, of course, pop them in the chat thread, or you can raise your hand or just unmute and ask any questions that you may have for Jeremy, or just comments in general, anything that might be on your mind. We're happy to answer as well. So there may be things that brought you here today, or things that you're struggling with in the clinic, or maybe something about your particular practice that you're trying to make a shift toward that you might need some support around.
Hey, Joe and Jeremy. Thank you guys for the talk this morning. I'm a physical therapist in Florida, and one thing that I'm kind of definitely struggling with, specifically for men in this area, is I find a huge barrier for them to feel open in talking about this. I find that a lot of my patients often can't really describe what's going on with them. How do you guys kind of help them begin to express and kind of be able to get these things out there so we can kind of like work through these different emotional responses with things that are now limiting them in their life and kind of bridge that gap for some patients that might not have the language or just knowledge of kind of what they're going through?
Yeah, you want me to start, Joe?
Sure, go ahead. Yeah.
I think the most important thing you just said was language, William. And I think, we learn our emotional vocabulary through our interactions with others as we grow up, whether that might be our core family, that might be the places we work and habit. But if that emotional vocabulary isn't there, then we need to help someone build that type of vocabulary. For me personally, that happens through building a great therapeutic alliance and also disclosing my own difficulties and struggles at times. So self-disclosure actually is a tool that I use to help someone else be able to see that it's okay to be vulnerable enough to share those things. I think that's something that's been really helpful for me as a clinician, but more importantly, helpful for the person that is looking for there. There is also other tools that we go over in the certification program too that help people to better understand emotional experiences and how they can use those.
Yeah, thanks for the question, William. So I would just add to that just one thing. When you come to the, psychologically informed physical therapy, mental health physical therapy space, there's a lot of, or even when you just start with pain neuroscience education, so to speak, which is oftentimes the inroad for a lot of PTs into this space. I think pain neuroscience education is a wonderful thing, and we should all be using it. It has provided us with this idea that we should be kind of talking or educating consistently with people, and there's definitely a place and a role for that. When people are struggling and they're unsure of their health and they're unsure of what they're experiencing, and they're dealing with either past traumas in their life or maybe even a current trauma in their life, it can be really difficult to find the words to describe what you're feeling. Now, ideally, we would love that, right? We would love people to say, I'm feeling really down and low and depressed, right? Those things obviously would help us to craft a plan and to help connect with our patient. But when you're feeling down and low and depressed, it can be really difficult to access words. There are neurological reasons for that. There are physiological reasons for that as well. So realize that words may not be the place that we want to start. We may want to start with, what are you noticing in your body? So are you noticing things that feel tight or constricted? Are you noticing areas that you have a lot of energy or you feel very activated, so to speak, right? A lot of people talk about triggering. I don't like the word trigger. I don't use that with patients because it obviously has connotations to things like guns and violence. Where in your body do you feel activated, or where in your body do you feel like you're not experiencing activation? So emotions, physiologic responses. And then I think the important thing that, I'm going to circle back to what Jeremy said is, what parts of your life were very full, and now it seems like you're not accessing that part of your life as much. So maybe you had a big group of 5 friends that you would see, once or twice a month, and you haven't been seeing those people. Why is that, so to speak? So you can work on a cognitive level, definitely. But when you start working on more of a whole person level, and we teach this in the program, we think of cognitions, emotions, Somatic experiences, like those three all together, are really good things to think about. So cognition, emotions or feelings, and then somatic experiences.
Thank you both. I feel like I've definitely heard the somatic experiences commonly, but kind of hearing the framework in which you put it in definitely brings a huge contextual factor that I wasn't even like thinking about. So thank you guys both.
You're welcome. What's
Yeah.
nice about the somatic part is that obviously that's easy for us as PTs to kind of start to talk about because we understand the physiology of the body. We understand the stress response. We understand when someone's very activated or in sympathetic mode. We understand when someone's kind of slightly deactivated or in parasympathetic mode. And I also want to make sure that when I say sympathetic and parasympathetic is people don't typically fall into one or the other. There are aspects of both that people are experiencing. So you might find that people are activated in some ways and they're also deactivated in some ways as well. And we have tools to obviously shift people in either direction, right? Really, what we're helping people do is shift their state. And when they shift their state, then they can shift their participation in life.
Yeah. I think I saw Grace had a question.
Yeah, I did see Grace's hand up.
Hi there. Thanks so much for the webinar. I just thought I would, show you, unmute and just talk on video. But I appreciate what you're trying to do. I'm a Canadian now based in the UK, and I'm a psychologist that specializes in psychotherapy. But one of my interests that I developed was in cognitive behavior therapy for chronic pain. And so one of the things that I came across in my learning was this Integrative Science Pain Institute, which I think is really great. And I know today is for physical therapists. So my question is, it does sound like an expansion in your scope of practice, which I think is really important to be able to help your clients in front of you. And I can appreciate the difficulties in being able to sort of refer because there are challenges and financial challenges and various resource limitations that come with all of these things. But just for your audience today and in your course, I just wondered if you could speak to what are some of the indications where you should refer on. And I guess in my school of thinking, Dr. Flesher or Jeremy Flesher mentioned that the use of self-disclosure. And so in my world, we use very selective self-disclosure within the confines of what is appropriate in therapy. So I just wondered if you could speak to both of those things. And thank you so much again.
Yeah.
Thank you for being here and for joining us on this webinar. It's really great that we have an interprofessional collaboration happening here. That's really what we want. We want our message, obviously, to reach physical therapists, but we also want our message to reach other licensed health professionals and for them to understand, obviously, what our role is. You know, the evidence is quite clear that physical therapists, obviously, we're licensed health professionals. In the United States, we're at the doctoral level. And in many jurisdictions in the United States, we're primary care providers. So we're directly in practice environments where this is really what our role is, right? To identify, screen. And we don't use the word refer out, we use the word co-manage. Now, obviously, there are times, right? So if a physical therapist is screening and they identify suicidal ideation, then sure, that's a direct referral. But in probably 90% of the cases that we're seeing with the therapists that have gone through our program is what this education helps facilitate really is the co-management of physical therapists with other licensed health service providers. So that could be a primary care doctor, it could be a psychologist, it could be a psychiatrist, it could be a licensed professional counselor, it could be a social worker, it could be a pastor, it could be a health coach. There are lots of different ways that we as physical therapists can co-collaborate and co-create really communities of healing with people around their whole person care. So that's kind of how we approach it in general in the certification and really what our graduates are doing in the communities kind of where they work. Jeremy, you want to add something to that?
Yeah, I'll briefly explain my role in the VA to give you some context about maybe how that actually looks like what that practice looks like. So, oftentimes I'll have people that are So I'm working predominantly in a veteran population where the incidence and prevalence of mental health disorders and illnesses are a lot higher. I'm also like the context in which I'm into in Lower Alabama across the Gulf Coast, a lot of barriers to mental health access, a lot of difficulties, things there. So my role as a primary care physical therapist then becomes like identifying and screening for things that they need the collaborative care approach or a more interdisciplinary approach. So in this particular case that I gave today, like I would also include in my communication and coordination section of my note and have like a behavioral health team member on that note so that they're notified, hey, this person screened this today. What's amazing, and I think a really great benefit of where I get to practice is I'm able to also look at the electronic medical record and see what their previous mental health screening has been. And so that also enables me to say, okay, this is a part of the clinical picture here. It's not the whole, but it's a part of the clinical picture here. And I can begin to develop intervention strategies that help address that. For example, mild to moderate, depression, the evidence is really supportive that exercise is probably more helpful in some cases than medications for certain. And so like that's another role that I get to play in my environment. You asked about selective self-disclosure, and I want to address that component too, because that's critical. I will say that one, I've had my own lived experience. Two, I've also had formal peer support specialist training, if you're familiar with the role that a peer support specialist plays. So really that's sort of the role that I'm inhabiting when I'm using self-disclosure is more as a peer, because I'm a veteran who's had a lived experience. I'm also a veteran who's had a deployment and combat experience. So like I'm relating in those terms. I definitely don't, I want to caution people that the therapeutic encounter is about the person that you're caring for, not about your own mental health. So there has to be an intentional use of disclosure there. And I think that's what you're getting at, or at least I'm assuming that, Grace.
If I can just respond, absolutely. Yeah, that's what I'm getting to. It's just important to really if you're engaging in this to really understand what is appropriate self-disclosure and what is inappropriate self-disclosure. And I can see the lens that you're looking at. And based on what you were saying, I think that this really, really has a place in a workplace that has multiple professionals and multiple inputs for support. But for example, if you're a physical therapist in private practice or in solo practice, integrating this, it just comes to mind that it's so important to build a network where you can refer and sort of safely support a client in a client-centric, needs-based way. So
I agree.
That's where I was coming from.
Yeah, absolutely. And I'm so thankful that you brought that up, because Joe and I talked a lot about that when we were developing the certification, and we include that as an activity, building your network of professionals within the certification, and how about going to doing that? Because I'll use the example of especially in the area of pelvic health physical therapy. So there are a lot of things that come up in sessions with pelvic health physical therapists that pelvic health physical therapists continue to tell us that, hey, these are the things we're hearing and we really don't know what to do with. So, we were like, listen, you need a collaborative approach. If you're going to do trauma-informed approaches where you're screening for these things, have a network of support before you engage in that activity first, so that you don't inadvertently traumatize someone, because that's also really critical as well. Joe, anything else you want to add to that?
No, I mean, obviously, trauma-informed care is a skill that I believe every practitioner should have, not just physical therapists. Jeremy does have a separate course on that here. It's 7 hours long. It's a fantastic course. It's one of our more popular courses. There are aspects of trauma-informed care kind of seeded throughout the mental health physical therapist certification program. So you receive that as well. The other thing I would say is what a lot of the graduates of certification have come back to us and shared with us, and this is probably consistent in my practice and Jeremy's practice as well, is that other health service providers, whether that's a primary care provider or a mental health provider, are really excited that we're integrating these types of skills into practice. And the reason why that is because we know that transdisciplinary care really is one of the gold standards, especially in areas like pain management, meaning oftentimes these skills need to be reinforced more than once by more than one provider. So if the physical therapist is reinforcing those skills, and let's say the psychologist is reinforcing those skills, it really is a kind of more really effective way to deliver care when the team, whether they're working under the same roof, which of course sometimes that exists, but oftentimes in the United States of America, we're a little bit more under our own roof, so to speak. So it's important that even if you're under your own roof, that we're all speaking the same language with the patient, really.
And Grace, I'm just so thankful that you're here today. But second, the VA actually has a really cool model where PTs and psychologists pair together to teach session-based coursework. And I've been a part of some of that, but not as much as I'd like to. And so it really is an innovation that I think is, being cultivated with this environment because of this intersectionality of mental and behavioral health and the need to integrate that in some way. So super grateful that you're here today.
And Grace, you're in the UK, right?
I am in the UK, yeah.
So the UK has a fantastic organization. I believe they're called the Charter of Physiotherapists in Mental Health. And I know a lot of those physiotherapists in the UK who are part of that charter are doing very similar, if not the exact same work as we're doing here. So this is, spreading across the globe, and they're a great resource for you to connect with and collaborate.
Well, thank you very much for sharing this, and thanks for having this today. And it's really great that you're doing this for men's mental health. I really appreciated that component, and I'm really happy to chat with both of you at any time further if there's anything that I might be able to support with, and especially to learn from you as well, because that collaborative care is so important for our clients, right? If we think from that piece, like from the heart, why are we all here? It's to really, we really want to help our clients. And given it's a Saturday, I think everybody here is looking to do that.
Yeah, that's right. Yeah, thanks, Grace.
Thank you. Anyone else? I'll take a quick peek at the chat thread. Of course, you're welcome to unmute and talk to us. Anyone else with questions, comments, anything you want to share that you found impactful from the presentation or things that you're doing in your practice that you'd like to share? All right, we're coming right up on the hour. I will send this out in a recording so you can access it if something you want to go back and listen to, or you want to look at the slides, you want to screenshot some slides. This will go out in an email tomorrow if you're not a part of I believe everyone is, but make sure you're signed up on the listserv or the mailing list at the Integrative Pain Science Institute. That way you can stay connected to everything we're doing, really an integrative and psychologically informed care. There'll be a replay sent out. If you have any questions, you can email us here at the Integrative Pain Science Institute. Our email is really easy. It's support@integrativePainScienceInstitute.com. You can also just go to the website. There's a contact form. You can fill that out. You know how to find me online and things like that. Okay. Thank you so much for being here to talk about men's mental health. Thank you so much to Dr. Jeremy Fletcher for sharing his wisdom today and his experience. Thank you to all of you for being part of our community. We do have webinars on a regular basis, so please stay tuned. We'll have more things coming up. All right. Thanks so much, everyone. We'll see you soon.